sang lay dentistry.
Conference. It's such a challenge anywhere in the world, and it's a wonderful turnout. So thank you very much. It's a huge honour to be here. I really enjoyed Dr. Lee's lecture just then. It was really fascinating. Now, if you flip the coin over, we're going to talk about something, a different type of mechanics, and that is something that is a passion of mine, Invisalign. It's been a passion now for 25 years. So Invisalign is like a baby to me. You may know I was educated in Australia and went to the United States for 8 years to do teaching and research. Actually, my professor in San Francisco, Professor Robert Boyd, had a lot to do with Yonsei University in Seoul, so maybe Dr. Lee actually knows him. But 25-year journey with Invisalign, and I want to share with you a little bit of my experience, mainly focusing on teenage treatments. If we fast forward the clock, here we are back in Melbourne. So I teach at Melbourne University, and it's a wonderful university, wonderful group of residents, and there we conduct obviously research, and we have a lot of fun learning together. The students very much challenge us all the time. This is my practice. My practice is not a big American style practice. Actually, it's in my home, part of my home, which I hear is maybe a little bit similar to Vietnam. Some dental practices are in the homes. It's only 2 chairs, so I do most of the clinical work myself. I don't delegate to many auxiliaries. Last week I came back from a wonderful vacation and I had a beautiful surprise here, my new iTero scanner. You'll know Invisalign is a very digital platform, so it's very different from our traditional orthodontic mechanics, and we're still learning so much about it. But as you'll see from my talk now and after lunch, that Invisalign really focuses on a digital platform, and that way I can have many benefits. Brackets and wires work beautifully. We saw that with Dr. Lee. It's analog. Invisalign system is digital. And as you know, Invisalign was the pioneer of digital orthodontics. There was no 3D tooth-moving software. Forget the actual program of the aligner. There was no tooth-moving software. And that's why our university, University of the Pacific, became excited. We didn't really envision Invisalign what we thought was a good teaching software material. But now 25 years later, you can see the evolution. There are similarities between fixed appliances, brackets and wires, and Invisalign. Both of them are force-driven systems. Invisalign is not displacement driven. It's not just the tooth moving in space. It programs forces that are necessary, just like we create with brackets and wires, and therefore we need attachments. So it's a combination of the attachments and the pressure points, which we don't see on the software, on the CleanCheck, that creates this force-driven system. Here we can see the difference between a force-driven system on top and a displacement-driven system. With brackets and wires and aligners, we push below the centre of resistance, or pull below the centre of resistance if it's fixed appliances. And this is a tipping force, right? Anything that's below the centre of resistance. So if we really want to treat complex malocclusion in this century, then we need a force-driven system. We need to be able to control the roots of the teeth. If you think about anything that has changed from analog to digital, what are the benefits and what are the changes that we see? If we think about the journey of the telephone from analog to digital, that illustrates in a picture how much change is possible in a very short time. And it's not just change, but it's usability and efficiency. This 2021 or 2022 phone now has so many more functions and possibilities than what we had originally. And when you think back to 1997, and that's when we started working with Invisalign, look at the telephone there. Already we've had so much evolution in just 25 years. And you'll see, I think from the discussion, that our capability, what we can treat, is so much more. Every day, because it's digital system, we're getting new tools that we can incorporate into our diagnosis and treatment planning, which is the fundamental of any orthodontic treatment. Right? It doesn't matter, the brackets and wires, the tags, the Invisalign, it's just mechanics. What's really important for us as clinicians is the diagnosis and treatment planning. And these, the possibility to diagnose and treatment plan with this digital system, seeing the roots on the teeth, radiographs, measuring tooth movement, is really fundamental to why I choose to use a digital orthodontic system. So you can see there is a platform that we can use to educate patients right up to retaining patients and, very importantly, diagnosing and treatment planning. When we look at this process, so what is the Invisalign system? Some of you here may use it, some may use it more than I do, and some may not. But what does it look like? Where does the doctor fit in? Where do we fit to this process? Is it just, you know, an aligner that we can get in the mail? It's not. It's very doctor-driven. So our role as clinicians is to run the software, to diagnose, to treatment plan, and very importantly, to program mechanics. This software programs the activation of the aligner. It's not just a picture, it directly helps manufacture and create the full system. And then of course our other responsibility as the treating doctor is the patient. The biggest variable in all of this system is not the aligner, it's the patient. And we know the patient the best. And as we know, they come in all different shapes and sizes. And as Dr. Lee was saying, some even with terrible faces. So what can we control here? Sometimes doctors who use Invisalign will see the system think, I don't like it because the company's in control, I'm not in control. Actually, I feel very much in control, but I need to know where I can have my input. So my goal is a treatment outcome that is the same or better than fixed appliances. We have control on the final position. So the final position on the software, it shows us our treatment goal and possibly some small overcorrection. Interproximal reduction, or IPR, is not necessary to treat an Invisalign patient, as you know. That is doctor-driven. We can use it for black triangles, Bolton's discrepancy, space gaining, but we're the one that program, not the company. Attachments and aligner features is part of the force-driven system. So there are aligner systems out there that are just displacement-driven, that don't use attachments, but the movements, they can move teeth for sure. So can my thumb move teeth. We need to control, if we want to treat in 4 dimensions, so that's including time, we need to control, and the attachments allow us that control. The staging. As you'll see from the cases, staging and changing staging and thinking about staging really makes a big difference to anchorage and what we can actually do when we move the teeth. How about the force systems? They're very hard to define. Even our brackets and wires that we've had for 120 years, if you were to write down the force system in vivo, it's impossible. We have general concepts, but every patient, it's going to be different, and that's the same with the aligners. Vertical dimension. So another reason that I love the Invisalign system is that I can do things that were very difficult with fixed appliances, very challenging or more invasive. I have great control over asymmetric mechanics. When patients come in with cans, then we can, as Dr. Lee beautifully showed us, put TADs in and use mechanics to impact the maxilla. And if I have patients that need maxillary paction, I'm going to send them to Yonsei to solve. But we can also use our Invisalign force-driven system and the attachments. These are all optimized attachments generated by the computer, and we can visualize now the simulation, the change in the patient's gingiva. And simply by using the aligner mechanics, which have great vertical control because we don't get spontaneous extrusion. Of course, it's equal and opposite. That's Newton's third law. But the geometry of the aligner is different from our brackets and wires. And it allows us to treat things that were very difficult or invasive with fixed appliances. So here you can see at a refinement stage, now we have a look and see what else needs to be done. And we can eliminate the can without total maxillary impaction, but at least creating an aesthetic appearance. Vertical dimension for single teeth, single intrusion of teeth. You know, this patient here had a very nasty scissor bite on the right-hand side, and very traditionally very difficult with fixed appliances. Here we can correct the scissor bite by intrusion of the posterior tooth. So just have a look. My first attempt didn't work very well because I just tried to slide across. Vertical control is what's needed. We intrude the terminal molar and then we can correct the transverse. Intrude, correct the transverse. And that control is very possible with aligners because of the geometry. So previously, yes, maybe a TAD or maybe extraction of that tooth. Now we can treat very well and control that vertical dimension with our aligners, simply because of that geometry difference. How about this patient here? Someone who comes into your clinic and says, I'm getting married in 6 months, and they have a very nasty aesthetic problem. You can see here, it's convex profile, but normal nasolabial angle, mild skeletal class 2. That chin-throat angle is not great, but she's not in for surgery. What we need to have a look at is see how can we improve the aesthetics before the wedding. Remember, we've got a time constraint. This is a difficult treatment planning problem. It's not, you know, Invisalign comes last, it's the mechanics. We have to decide, what's our treatment plan here? What's possible? Are we going to extract the lateral? Still not going to look good, the midlines will be off. So my treatment plan was to distalize. And we have a fantastic distalizing appliance with aligners and elastics. Of course, this takes compliance, so patients have to understand what we're going to ask of them. Nothing comes for free. So whether it's more invasive or less aesthetic, or you know, they have to wear elastics, then the patient needs to understand what's involved. So this is a slide that I go through with every new patient.
Getting to the template. Insert cheek retractors and etch the teeth that will receive attachments.
We can stop that attachment.
You can use either the treatment overview form or the template itself to identify the teeth and location of the attachments. Depending on how many attachments are to be placed and ease of isolation.
Sorry, I'll get rid of that, it's too loud. But that slide shows the patient what's involved in the treatment. So that when we come to say, now you need to wear elastics, otherwise we're not going to be able to distalize, the patient doesn't say what. Or we put on attachments and they say, what's an attachment? They need to understand what's involved. So very quickly in pictures we can show them. So this is Lexi's treatment, her first clean check plan. And you can see lower arch is really level and aligned. The upper arch, we have to do some good distalizing on that upper left-hand side, a little bit on the right, over-distalized to a super class 1. This is actually, it's not as difficult as what it looks because really the anterior limit was not changing a lot. So if we, I'm just trying to go back to that. The anterior limit of the incisors, almost the arch length is increasing. And one of the rules we have that I've learned over 25 years, when arch length with the Invisalign increases, we have good control of movement. When we decrease arch length, like extraction case, even a class 1 spacing case, or at the end of distalization, this is when we have to be careful. This is when we tip molars, lose torque, end up with a buccal open bite. But here, because there's so much crowding, the arch length is actually increasing. It's not decreasing. So we had to stop early because the wedding came. So while the wedding was on, we took off the attachments, she went to get married, it was a little bit more aesthetic. Then we programmed the additional aligners, the finishing aligners. Whenever I treat a case with Invisalign, yes, it's digital, but we're never going to get 100% of the computer. Never. That's impossible because it's engineering error, as well as the biggest variable is the patient. Some patients are 5, some are 95. Some will be 16 hours a day, some will be 22 hours a day. Every patient has different bone, different roots, so we're never going to get 100% of the clean check. So for that reason, I always tell the patients that I will have a finishing series, at least one series, that's my goal, only one finishing series. If it's complex like an impacted canine, then it might be 2 or 3. Just to make sure that we get close enough to our clinical goal and make up that difference in expression between the software and the patient. So here we're just finishing off our leveling and aligning, little buccal root torque. I've learned to finish a lot, a lot smarter these days. Finishing with Invisalign starts right at the beginning. It's not something like fixed appliances at the end. We have to think about it at the beginning in the software. Distalizing I like to think about as juggling. And we can't have all the balls in the air at once. Something has to be controlled. Otherwise, we're going to use TADs, right? If we want to use everything at once, or surgery.
If you really want to impress your friends, 7-ball juggling is for you. It does take a lot of time to learn. This is what it looks like.
He has great control. Some balls are moving in the air, but others are standing still. And we have to use that concept, or I use that concept when I evaluate what is the anchorage potential of this distalization case. And every case is different. So here, the distalization, we can see anecdotally and also in the literature, actually is one of the best expressing movements that we can do with Invisalign. So now we have class 1 canine molar, midline's on, lateral ready for a second honeymoon. And we have what Dr. Lee was calling, the terrible face with the retrocline incisors. Vertical control is beautiful. Remember, we can't extrude or open that mandibular plane unless we program extrusion. What's the problem with Invisalign? It's not extrusion, it's unwanted intrusion. So that's what we need to control. How tight that posterior occlusion is going to be. So nice parallel roots and efficient distalization. You can read about those kinds of cases. This is back in JCO in 2018 with Dr. Samoto from Tokyo, who I think is one of the greatest Invisalign doctors, and started very early in the career in Tokyo. So what age are we treating our patients? Invisalign started, as you can see, as an adult aimed, because we didn't know what it could do, what it was capable of when it started. And I guess compliance was a thought that young patients wouldn't be able to cope with this kind of a system, which is really strange to me, and you'll see why. But orthodontists have been asking, you know, our forefathers, really clever people, since the 30s and before, what age should we start treating orthodontically? If we look at most of your practices, orthodontic practices, or at least my colleagues, most of them treat the teenage era. And that's probably for a few good reasons. We have the potential of growth and growth modification, or using growth to achieve our results. Not the stigma, perhaps, of wearing braces as a teen. There are lots of good reasons to treat in these early formative years. But is it the teenage dream with Invisalign? Not every patient is going to be beautiful and compliant and, you know, just have a mild class 1 crowding malocclusion. This is, you know, not a challenging case for Invisalign mechanics, and a beautiful patient who's going to be compliant, wear her aligners 20 to 22 hours a day, change every aligner every 7 days, put the new one in at night before she goes to bed, and keep everything nice and clean. So not challenging at all. You can see, you know, very minor alignment, these small optimized attachments. Invisalign has 2 kinds of attachments for those of you who don't use it. One are the computer generated, the small smart ones that look at the force-driven system, so they're calculated to be positioned where they are. And the other type are the generic. It's just a surface area to push on. So here we go, and you know, we go through the first series. It was 12 aligners in the first, then we go through the second refinement series, very minor correction, minor finishing, and we have our result. Not every teen patient is going to be like that, but that's what we want, right? That's the teenage dream. What about the elephant in the room? The elephant in the room is, of course, compliance, which, as I said, I think is really strange. Because as orthodontists, we treatment plan our patients to wear all of these things. And we never think about compliance. And even when we've spent 2 years making the most beautiful creation, the most beautiful, functional, aesthetic occlusion, we give them this kind of a retainer quite often. And we say, this is your insurance, wear it for life. And that's removable, and that needs compliance. Or maybe an S6 retainer. But we never really question any of this. And I put to you that wearing an aligner is much easier than wearing any of these very common orthodontic appliances. What I find usually is not the teenage patient, the issue with the compliant, it's the parents. It's our hang-up, our misconception. So we transform teenagers one parent at a time. I like this article. I'm sorry, it's in English. I don't know if it's translated into Taiwanese. This Chris Hudson, he's a youth specialist, and he has this great article on 7 secrets of motivating teenagers. And you know, I want to share with you some of these tips in motivating teenagers, and as well go through a few 10 cases. Let them learn from other people's experience, whether it's a social blog, whether it's, you know, often I'll have a patient in the chair and a patient come into the clinic, and I'll get them to talk to each other. I'll say, hey, you know, Jimmy, this is Bobby, and he's going to start his treatment. Why don't you tell him what it's like? And I think they believe their peers much more than perhaps they believe me at the beginning. Then we form a good, trustful relationship, and of course that's part of successful treatment. So this little boy comes from the country. He hates his front teeth, 11 years old, beautiful little boy, very convex profile. So yes, perhaps some of you might think of functional appliance. I like to think of aligners and elastics as a functional appliance, and there are lots of traditional papers that will actually suggest this as well. Very severe upper incisor proclination, as you can see. The actual skeletal relationship is not so bad, it's really the upper incisor proclination. So we can start treating right now, but if the teeth are exfoliating and changing and I do my scan, then by the time I manufacture, the teeth may have changed. So I waited for a little bit further eruption. These days we have Invisalign first. We can treat in the mixed dentition if we want to, but I don't want to, I want to make treatment efficient and expedient. So as long as the trauma risk is fairly low and he can cope with those incisors, then I will wait till I have a little bit more tooth eruption. So the treatment plan here, you could have a lot of treatment plans. You could possibly extract in the upper, although the crowding wasn't that severe. You could, his skeletal class 2 wasn't too bad, but perhaps some would use a functional. My treatment plan was to distalize. And my inspiration for distalization is nature. First it was the juggler, when I start, thinking about how is Invisalign actually working when we do this? And then I think about, is it possible to move one body and translate it a bit at a time? Where is the anchorage coming from? So the caterpillar uses the front and then picks up the middle and then the end. And that's what I use this principle for my class 2 staging. I distalize the molars first, and that way I have a beautiful anchorage segment, 5 to 5, while my 2 molars are going back together. Just look at the root mass difference. Even the patient doesn't particularly need to run elastics here, although I do start them early. Then once the molars have distalized and stopped, my arch length is increased. It's a very safe movement. Now I start to concentrate on the green zone, the canine and the premolars. And I call that the green zone. You'll see when we look at a transposition patient, we can have beautiful control. In extraction cases or translating teeth, it's not the tipping in the middle that ruins our outcome. It's the loss of torque and the molar tip. So this green zone works very nicely as long as our arch length is fixed. And then we move the incisors. So we retract the incisors, and that's where we have to be careful. And that's why it's good when we start with a patient with proclined incisors. If the incisors are retroclined, straight from the first phase, we actually procline them, prepare the inclination for retraction, because we know that aligners are going to push below the center of resistance, and if we just retract, we won't have the moment possibility, there won't be enough moment to correct that reposition. So as we're distalizing the molars, we prepare the incisors if they need it, then the molars stop, then we distalize the canine and premolar, and then finally, this is the most challenging part in extraction or distalization, the incisors, because everyone's looking at the incisors. What else, what don't we see? We don't see the molars, the equal and opposite force. But now we have a really nice anchorage segment. We just have to control the torque on 4 incisors, and we've already prepared that inclination for a little bit of torque loss. Patients need to understand and be part of this process. So instead of just giving them the big book that comes with the aligners that is very complex, that young patients probably can't understand, we make our own. We make it for teenagers and we make it for younger patients. Very simple instructions because it's a patient-driven appliance, so they need to understand it. So you can see Finn's ClinCheck plan here. Very deep bite. The other thing we need to control, we need to level that lower arch, otherwise we're going to get incisor interference and a buccal open bite. So what we're going to do here, distalize the molars, then the canine is extruding in the premolars, and finally the incisors. Straight away we're looking at the vertical dimension of the lower arch, intruding the canine, and then the incisors, and the canine incisor. And that's, some of you may know, frogging, and it's really the vertical of Dr. Samoto's retraction in extraction cases, that frogging stage. So this way we have great anchorage control. I stopped a little bit early here because anyone who uses Invisalign tells you what's the hardest tooth to move? The lateral incisors, right? Especially when you're retracting them a long way. Even if you're not moving them, they will respond to a canine movement, the tooth next door. They don't have an undercut and they just intrude. So we did an early refinement here. The distalization was going well, but I wanted a new aligner for this upper left incisor. And with the scanner, when I do this, it doesn't take long. It's 10 minutes. Scan, take photos, and that's it. I can reprogram. So this is the reprogramming. Continue with my distalization and leveling, although most of the leveling on the lower is actually already achieved. The incisor inclination maintains during retraction. Even though they're very protrusive, I can always flatten them, but it's much harder to push the root back through the bone and create that torque. So that's the finishing series, and here's 17 months from a full unit class, a full unit class 2 canine to a nice class 1 canine and a nice level lower arch. No opening of the mandibular plane angle. That's repeated over and over. 25 years of Invisalign. I think I've seen 2 cephalometric tracings that show possibly opening of the mandibular plane angle. So very good vertical control and a happy patient. Now you can see the superposition, the distalization of the upper molar and that retraction of the upper incisor. This is, also in the journal articles. This is an article here that measures the efficiency of distalization. And as I said, it's a very efficient movement.
My name is Davian, and I have excessive overjet and...
So we can see that in Invisalign we can treat teens and now first dentition, mixed dentition patients as well. The second thing, patients ask, what's in it for me? And this is probably the most important motivator for a teen or even an adult, but particularly teens. What's in it for me? They need to see some benefit. It's not because mum wants me to have straight teeth or my dentist wants me to have straight teeth. This is a patient here with impacted canines, and what she wants to do is keep living. She wants to go out and socialise. She doesn't want braces. She's just discovering boys. So we treatment planned her for crossbite correction, arch preparation, so that we can create the space. The sequence is the same as what we do with fixed appliances. Remember, Invisalign is just a mechanics. It doesn't change our treatment planning. We do the same sequence as we would with fixed appliances. We make space in the arch, and then we surgically expose, and then we can use the lower aligner as the mechanics to extrude the canine. So this is an example of the lower aligner, and this is all planned on the ClinCheck software. We place a little hook. I just cut a little eyelet, a little hook here on the exposed canine, and then we create some crown length so that when we rescan, we can now incorporate that canine into the treatment plan. So as the canine gets closer into the arch, we have more control. As we get more arch length, we have more control. And then we can start to use our force-driven system, because the important thing is not to leave the root behind. So we're going to need some kind of torque here. You can see I'm using a buckle and a palatal attachment on that canine because the crown is so short. So, the treatment planning potential for Invisalign in treating more severe patients is really increasing every day, just like most digital systems. It's evolving and it's evolving so that we can tell this patient what's in it for me. We're going to listen to you and we're going to give you something aesthetic. We're going to help you remember to change your aligners. We can do that quite easily by Invisalign virtual care. So now they have a process where we can contact the patient, they can send us photographs. You've probably heard about these things, especially during COVID. Remote monitoring became very popular. You know, the tele-dentistry, if only everything could be done remotely. But there are these apps now that are integrated with the system so that we can help these patients if they do have an issue with remembering aligner change and compliance. So what's in it for me? This patient can go from something that's totally unaesthetic, in treatment looking really quite aesthetic, and continue good oral hygiene, eat what she wants, go out and socialise, and even take a date to her school formal. How about class 3? These are two sisters, and really the message here is obviously COCR shift. Be careful of that. But the message here is when you have two sisters or siblings, it's fantastic because they almost compete with each other. What number are you changing into? Are you wearing your aligner? And they really help each other get through their treatment. As I said, just like class 2 distalization, aligners with elastics, when you take away that factor of occlusion most of the time, then perhaps we're getting some kind of functional effect, which I don't have evidence for. We need a big patient pool, but perhaps someone in the audience who works at the university is going to help conduct that study. Do we get a functional effect with long-term aligner wear and elastics? So we want to make it fun. This is Alexa. She had polio as a child, not happy, and you can see, you know, quite a significant class 3, very flattening of the zygomatic arch. So you could treatment plan her, you could wait for surgery till she's an adult. Her mother was begging me to do something because she was a very unhappy child, but no extractions and no surgery. So, you know, it's the patient, like the Korean patients Dr. Lee was talking about, they want everything. But 13-year-old, concave profile, very low smile line, so all of the typical characteristics of that class 3. And there you can see cephalometrically the already compensating upper incisors. So what can we do if we're not extracting and if we're not performing surgery? You can also see vertical discrepancy, and that's really important to treat the vertical before the transverse, overbite before overjet, just like fixed appliances. So what we planned for was some lower distalization. So distalization works well. Of course, we have to take into account the anatomy, impacted third molars, the ramus, make sure that there is actually room there to distalize. We can measure very accurately using these numbers, the degree of distalization. Of course, we know that we're not going to get 100%, and even on the crown, let alone the root. But we can use those numbers to program the desired amount of movement, knowing that we won't get that 100%. So upper arch, we have to be careful not to tip out the upper aligners too far, at the upper incisors, because they're already compensating. Okay, so this is where we came. This is where Alexa came. The distalization on the lower works beautiful. This is the next scan. She only had that second series. The lower is almost level. Here we have to tidy up a little bit. The upper's looking quite good. So a little bit of finishing. This is the wire bending, the rebracketing, in order to achieve that beautiful, much more functional occlusion. Of course, leaving a little bit of excess overjet in case her growth is unfavourable, or in case, because we know we're not going to get that 100%. So again, oh sorry, I'm having fun with this changer. Yes, third molar is definitely a consideration when we do this. Always checking the roots very well. These days we have the beauty of cone beam, and now we can see cone beam roots in the Invisalign system, so that will be very useful for these patients in terms of diagnosis and planning and evaluating our treatment outcome. So you can see the upper incisors were fairly well maintained in terms of the inclination. We didn't have a lot more compensation, and the lower arch, again, controlled really nicely to gain that distalization, that class 1 canine and molar. So we can turn a patient, a nice teenage patient who started out miserable, into someone who's very, very happy, even when they're in treatment. So they don't have to wait 2 years or 2.5 years or 3 years. They can wear this aesthetic appliance in treatment and have this amazing profile change. So if you look at the profile here, that change, this is what I mean by it's, you know, possibly a functional effect because we've had the aligners and the elastics working. So that's the initial profile here, and then that soft tissue change. And we have a nice happy patient. So what about something also that's traditionally challenging with fixed appliances, asymmetric mechanics? We tend to have a bit of a challenge because of the geometry of the brackets and wires. We're always getting reciprocal movement, and we can create cants where we don't want to. This patient here has a crazy tooth, and you can see her chief, or you could see her chief concern. She's a beautiful 13-year-old girl, skeletal class 2, proclined upper and lower incisors. She still has the 6'3" in situ, and most importantly, half a unit class 2 and transposed canine and premolar. So you can see the transposition here. So quite a challenge. And she was actually sent to me from an orthodontist who didn't want to attempt it with aligners because she wanted to use aligners to correct her crazy tooth. So what we did, we provide incentives. The incentive for her was that yes, we could treat aesthetically. We treatment plan and then program our mechanics very carefully. We're translating a tooth more than 2 millimeters. We need a lot of control. Anything more than 2 millimeters for me, I'm on the top of my game looking at what attachments I have, where is the root position. Again, now I'll be able to use cone beam to assess that, which will be wonderful. When Madison was treated, we didn't have the integrated cone beam. Lower arch, we have a rotation here on that lower right premolar. So I'm using, trying to get my moment of force into the aligners because again, there was no optimized rotation attachment there. But very nicely, we can provide her the incentives. She used her munchie. We have all the fun things like stickables on the aligners for the young patients, which are really cute. But she was happy just wearing nice aesthetic aligners. And this is after the first series of aligners. So our refinement, or AA, is additional aligner. 13 months of treatment. The transposition is treated quite safely. Have to watch out for this premolar root apex up here, especially if you try and detail it like a canine. And then a short refinement period. Actually, she came back to me 2 years later. Her general dentist sent her back because now her 12-year-old molars were coming up and I had to correct those. And that's something that we have to consider if we're treating patients earlier. Not everything is always going to be erupted, and we don't want to forget about the 12-year-old molars. They have a right to be aligned as well. So she came back and we did some treatment planning and a short series of aligners to put the 12-year-old molars in line. And of course we can check the occlusion using the scanner and the occlusal contact. So the minute I scan, even in monitoring, I can see quite accurately where those occlusal contacts are going to be, or where they are in the patient. So our key messages for today, the Invisalign system can be used to treat a range of patients. So I hope that this is just a random example of patients from traditional adult patient right down to the teen patients with different kinds of treatment plans. Don't underestimate the ability of teenagers to comply. We kept this appliance away from them for way too long. And we were still giving out Essex retainers and Hawleys and face masks, but now, the compliance with Invisalign can be controlled very well. There are studies that show that we can't ever predict compliance of our patients, but what we can do, the most important variable, is the doctor-patient relationship. And that's whether we're using brackets and wires, but particularly Invisalign, which is an appliance that's very patient-driven. It's reliant on that compliance. So forming a solid relationship, which is what I love. I love to spend the time talking to my patients. And I hope you can see that there are digital tools available now that help us from the education to the mechanical programming right up until the retention of our patients, so that we can help them benefit socially and physically and mentally. So I like to make it fun. Invisalign is part of pop culture. There is a video there, but